Hello guys, welcome back to ultrasound teaching videos with Dr. Arshad Nadeem Awan. Hope you're all okay. Hope you're all enjoying your life and also enjoying practicing ultrasound as well. I have been asked to describe and to give demonstration on the pelvic region, gyne ultrasound, obstetrics ultrasound. As you all know that I have been covering abdominal region. I have covered all the organs related to abdominal cavity apart from kidneys. Kidneys still left. I'm gonna address kidneys and discuss about the kidneys in later videos. But because of the people demand and my colleagues, they keep asking me to start the pelvic teaching. So I think it's better and it's the best time to start the teaching regarding pelvic region. So today my topic of discussion is pelvic organs, especially in regard to gynecology. The start would be from the gyne, and then I will switch on the obstetrics as well. But as you know that gyne is a vast subject and we have to cover many things. There are so many confusion related to myometrial endometrial interface when we are taking a measurement of the endometrium. There is again confusion regarding myometrial echogenicity and its different pattern, adenomyosis. Many a time we confuse or sometimes we miss all these diagnoses because of lack of experiences. But I'm pretty much sure that these videos will definitely help you in finding out all these subtle abnormalities. The another point is, so far the uterine positions are concerned, anteverted, anteflex. Many of the clinicians are still confused how we can label that and what would be the condition. So this video will help you to identify all these positions as well. So keep watching all these videos. And the second thing is, like as I mentioned, this is very important topic, and it need a vast understanding of anatomy especially. So before going to jump on the other factors, this video will contain only the anatomical and the radiological anatomical presentation on the ultrasonography. But before going to discuss all that, I'm gonna review anatomy, slightly anatomy. I'm pretty much sure you all know about the anatomy, but just for the revision, for a better understanding, first we will look for the anatomy, and then after that we will look for the radiological anatomy, its positions and different types of the ultrasound what we can offer for the gyne examination. So this video will definitely help you a lot. So let's start from the anatomy of the pelvic region, especially uterus, ovaries and fallopian tube. It is just a quick review for the pelvic anatomy. On the image you can see a well-defined uterus. There is a uterine body, cervix is already marked, fundal region. So normally there are three parts of the uterus: uterine body, uterine fundus and cervix. It's quite visible here. Beside this, on the both side you can see fallopian tube. Fallopian tube are attached with the uterus. That part where the attachment takes place is called as carnum and isthmus as well, which has no radiological importance so far this scanning is concerned. You have to just pay attention to the ovaries. There are two ovaries and the area in between, which is actually covering fallopian tube and the ovary. This area is called as a broad ligament. Beside the broad ligament there is another ligament which is also worth important, is suspensory ligament of the ovary. So far the ultrasound imaging is concerned, you have to just pay attention to the uterine body, fundus and cervical region, and also pay attention to the ovaries because these can be easily scanned on the ultrasound imaging. So far fallopian tubes are concerned, you cannot see fallopian tube normally. If they are normal in size and normal in shape, so you cannot visualize the normal fallopian tube because it's a tubular structure until unless it is enlarged because of any pathology, could be hydrosulfings, pyosulfings, or any other malignant masses, or even sometime pregnancy. So then you can appreciate the fallopian tube, otherwise you can't appreciate. So this is the normal anatomical review, and in this shape you can see these all structures on the ultrasound imaging. As far as the ultrasound techniques are concerned in respect to gynecological examination, so we have a trans-abdominal scan, widely used and can easily be performed and can pick lot of points. In case of any confusion, the another option that we have that is a transvaginal ultrasound. Transvaginal ultrasound give us a detailed examinations of the intrauterine cavity, especially endometrial thickening, the location of the IUCD or endometrial polyps. So this would be best for the performing of all these pathologies by the transvaginal ultrasound. Uh, Apart from the abdominal ultrasound, transvaginal ultrasound, now the third evolution is three-dimensional ultrasound or 3D ultrasound. This 3D ultrasound can be performed through the transvaginal probe, and you can again look in different dimension the uterine cavity and its pathology. The another procedure that can be performed is sonohysterography. Like self-angiohysterography can be performed for the X-rays purpose. We inject the dye and we take the X-rays, and through this procedure the uterus and the fallopian tube can easily project on the X-ray. But so far sonohysterography is concerned, we inject either the sterile water, or the gel can also be used to inject inside, and through that we can through the transvaginal ultrasonography we can look to the internal organ or the internal areas of the uterus. So these four are the important tool which we can apply to detect any of the pathology related to gynecologically or gyne organs. Before going to talk, so far the transabdominal ultrasound, as I mentioned, it's widely used and we will discuss all about that. It's very easy, just put the probe on the pelvic region and everything would be clear. The only thing that you need is the full bladder. If you full bladder will work as a acoustic window, and it will help you and it will project all the pelvic organ easily. But for the transvaginal ultrasound give rise to many detailed like information. So therefore you can perform that on empty bladder. If there is empty bladder, and you can through the transvaginal probe you can scan the internal organs of the female reproductive system. So what are the advantages of the transvaginal ultrasound? So let's start, and we are going to discuss about the importance of the transvaginal ultrasound. For the pelvic ultrasound, normally there are two types of the scanning, transabdominal and transvaginal ultrasonography. So advantage of the transvaginal sonography is that it has high frequency transducer, and it's very good for the people, for the patients who are unable to fill their bladders. The second thing, if patient BMI is increased, so you can also use the transvaginal sonography for the pelvic scan. In case of retroverted or retroflexed uterus, transabdominal will not give you a detailed picture, so transvaginal scanning can be opted. It's better for the characterization of the internal characteristics of the pelvic mass. If there is any mass, so you can easily look to the internal structures of the mass. It also give you a good detail of the pelvic lesion if there is any, and also you can evaluate the endometrial thickening, endometrial polyp, endometrial hyperplasia on the transvaginal ultrasound. Uterine position, ultrasonographic position. This I am talking in respect of the positions of the ultrasound, the position of the uterus, which we can see on the ultrasonography. There is a lot of confusion, and many a time we are describing only a few terms, but sometimes we can wrongly use these words, and we really do not know what we are gonna describe on that ultrasound paper or ultrasound reporting. So far the flexions are concerned, there are two words we commonly use. So far the uterine positions are concerned, it's anteverted or antiflex, or retroverted or retroflex. So far the versions are concerned, whether it is anteverted or retroverted, this is related to the position of the uterus in sagittal section with the vaginal wall. So vagina and the uterus position is considered to be a version, so that is called as an antiversion or retroversion. If it is anti-wise with the vagina, so that would be called as an antiverted, and if it is a retro towards the vagina, so this is called as an retroversion. So far the flexed is concerned, it is the connection of the uterus, the connection of the uterine body with respect to the cervix. So through the cervix, if it is aligned with the the cervix, so that is called as antiflex, and if it is not aligned with the cervix, so that is called as a retroflex. But again, I'm going to talk about the easiest way. This is really a bit confusing. If you keep this in mind, we have to careful in respect to the vagina, in respect to the cervix, it will again become very confused. So just forget about all that. There are certain pictures, you have to keep that in your view. The main thing is that what you need is, so far the pictures are concerned, the thing or the pictures you can see on the ultrasonic images, you have to write that on your report, and this will clarify very easily. These few slides I have, so just keep watching all these slides time and again, and so far the mystery of these antiflex and retroflex and antiverted and retroverted is concerned, it will be clarified. Another thing is, this position is also subjected to the bladder filling and sometimes rectal filling as well. So make sure that the bladder of the patient is fully distended, so that you can rightly mention which position of the uterus is. So therefore make sure that the bladder of the patient is full. So before going to discuss anything more and making you confused, I'm not intended to make you people confused. Just start jumping on these slides and find out how we can differentiate different positions of the uterus on the ultrasonography. On this transabdominal ultrasound, uterus is clearly visible. You can appreciate its fundus, body and cervix clearly. Vaginal wall can also be seen on the image. Endometrial lining to some extent can also be appreciated. This uterus position is anteverted. Look it in comparison with the vaginal wall. So it is anteverted and it is anti-flexed as well. Look in comparison with the cervix. So urinary bladder is fully distended, and you can comment on the uterus position confidently. It is anteverted and anti-flexed uterus on transabdominal image. This is transvaginal scan, and on this transvaginal scan you can appreciate a well-defined uterus. Fundus is visible, body is visible, cervix is visible. But the one thing worth noting here, the position of the uterus is retroverted. So verted version is a comparison with the vaginal. So you can see that vaginal canal, this uterus lies posterior to the vaginal canal on the image, so that's why it is called as retroverted. So far the flexion is concerned, again it is posterior to the cervix as well, so this is retroflexed as well. So on the transvaginal ultrasound you can clearly see that this uterus is retroverted and retroflexed. Other components of the uterus can easily be seen. Uterine cavity can easily be seen, endometrial thickening can easily be measured. So far the myometrial area is concerned, it is quite clearly visible, it's all homogeneous, there is no fibroid activity, there is no endometrial thickening. So this is a normal retroverted retroflexed uterus on transvaginal scan. This is another transvaginal scan. On this transvaginal scan you can see the uterus position that is anteverted. So for the version is concerned, it is anteverted, although you cannot see the bladder part clearly, because for the transvaginal scan you need to have the empty bladder, so therefore in respect to the bladder you can't comment on that. But as far as the other areas are concerned, it's quite clearly visible. So it is anteverted and but retroflexed. So far the flexion is concerned, it's slightly flexed, not clearly flexed, it is slightly flexed. So far the cervical region is concerned. So on the transvaginal scan, this uterus position is anteverted and retroflexed. On the image you can see small free fluid in the cul-de-sac. So in the cul-de-sac there is a fluid as well, so this could be physiological or sometime it could also be pathological. So this is another point, we will clarify it on the next videos. But so far the position is concerned, this is anteverted retroflex uterus on transvaginal scan. On this ultrasound image, this is actually transvaginal scan, and on this transvaginal scan, although uterus is not clearly visible, but its position is axial. This is called as axial uterine position. You cannot clearly comment on its flexion because uterus is not clearly visible here. Small fluid collection is also visible within the cul-de-sac. So far the parenchyma of the uterus is concerned, it's bit heterogeneous, so it's slightly heterogeneous myometrium. Endometrial canal is not clearly visible. A small cyst in the area of cervix can be seen. It may likely be Nabothean cyst, but anyhow this image is not so clear. It is axial uterine position. Endometrial assessment on the ultrasound imaging. It is really very important in many regards, like in premenopausal conditions, especially when patient is menstruating. So there are cyclic changes, there are proliferative phase, secretory phase, and menstrual phase. So endometrium responds to all these phases. So far the endometrial structure is concerned, it has two layers, superficial layer and deep layer. Superficial layer is called as functionalis layer, while deep layer is called as basalis layer. During the menstruation, functionalis layer gradually sheds in the form of menses, but deep layer or basal layer remain intact, which is supplied by the spiral arteries, and this is what the whole structure of the endometrium is. So for the measurement is concerned, you have to take the measurement in the long axis, but you have to take the sagittal plane. Take the measurement in sagittal plane, but make sure that you are doing or you are taking it in the long axis. And the second point is, if there is any fluid within the uterine cavity and you are taking the measurement, so ignore the fluid. You have to take the measurement without fluid. Like there are, as I mentioned, two layers, basalis layer and functionalis layer. So you have to take the measurement in long axis of the endometrium, in sagittal plane, and you should not take the measurement if there is any fluid. So far the endometrial proliferation is concerned, it is subjected to estrogen and progesterone. During the menstrual cycle, as you know, there are three phases: proliferative phase, secretory phase, and menstrual phase. uh, Endometrium within the proliferative phase, it may be subdivided into early proliferative phase and secretory phase, which is ranging from 1 millimeter until 10 millimeters. So within that, this would be considered as proliferative phase. While in secretory phase, secretory activity starts within the endometrium, and it gets thickened and echogenic as well. So that could be measured from uh, 11, 12 until 22 or 23 in the late pre-menstrual time. So you have to be very careful while you are taking the measurement, because it is very important in respect of dysfunctional uterine bleeding. If there is any uterine polyps, especially endometrial polyps, or if the patient is on the treatment for the fertility. So because all these investigations are important, because we have to keep in mind that which medicine is affecting on the endometrium and what is the process of the endometrium proliferation in response to the ovulation. So for the premenstrual conditions are concerned, in premenopausal women, it should have never been more than 5 millimeter. Normally it is considered that a postmenstrual uterine endometrial thickening it should have been up to 5 millimeter. If you come across any thickened endometrium, it could have been pathological, and you have to look for the other reasons as well, and it is important to further investigate that patient. So this was all about the endometrial thickening, which is really a very technical subject, and you pay attention when you are taking measurement of the endometrium. How it will appear on the ultrasound imaging, how we will differentiate all these uh, you can say phases of the endometrium. Well, I haven't seen a clinician writing all these phases on the report, but it would be really smart enough to mention, if you are confident, taking the patient's last menstrual history in view, and measurement of the endometrium on the ultrasound in view. If you can predict, or if you can mention, then this is proliferative phase or menstrual phase or secretory phase, this would be really very helpful. So how it will appear on the ultrasound images, let's start watching these images, and I'm sure you will be able to demonstrate and to write properly and accurately the phases of the endometrium. This is a transvaginal scan, and you can appreciate a well-defined uterus. Myometrium is fine, and this is actually antiverted, anti-flexed uterus. This scan was performed to measure the endometrial lining, endometrial thickening. Here on this image you can see this patient was in menstrual phase, because the endometrial lining is very thin. The shedding of the functionalis layer has been occurred, so therefore you can see only the basalis layer or a baseline layer. You normally know endometrium has two lines, functional layer and basal layer. Basal layer remain intact, while functional layer it sheds during the menstruation. So on this image you can appreciate that patient was in menstrual phase, and the endometrial thickening was nearly from 2 to 3 millimeter, and that was actually basically it was basal line endometrium. Myometrial and endometrial interface can easily be seen, so always pay attention, especially when there is menstrual phase to the myometrial and endometrial interface. So here everything is clear. It is a normal uterus with menstrual phase, menstrual activity. Patient will give you the history, also put on your report that the last menstrual period was blah blah, whatever you did find, and then on the report confidently mention that the endometrial thickening was 2 to 3 mm with the history of patient having menstrual phase. This is another transvaginal scan, and this was also done for the evaluation of the endometrial thickening. Here on this image you can appreciate well-defined uterus. It is retroverted, it is antiverted, anti-flexed. Fundus is clearly visible, myometrium is clearly visible, endometrium can be seen, which is not very thick, as because patient is in the menstrual phase. But another point worth mentioning here, this white arrow indicate small fluid collection within the uterine cavity. During the menstrual phase, it is likely that you may have small fluid collection within the uterine cavity. If it is small, if it is scanty, or if it is trace, so that is absolutely fine. But if in case it is large enough, in milliliters, you can give the approximate volume, so this could be pathological. So mention this on your report that the endometrial thickening is measuring, whatever the measuring is, you must mention the measurement, and after that mention that within the uterine cavity that much amount of the fluid was visible. So if it is trace, if it is very mild or minimal or streaks of fluid, you can mention that this is physiological process during the menstrual phase and clearly put on your report. because if you are just mentioning fluid and you are not correlating it with your diagnosis, so your colleague, your GP or surgeon or gynecologist may get confused that what does it mean. So therefore you have to exclude the pathology. If it is non-pathological, so put it small fluid, that could be physiological. But if it is pathological, always mention that this is a pathological fluid. This can clearly showing you endometrium in the menstrual phase with small fluid collection within the uterine cavity. This transvaginal scan shows uterus. Here uterus is clearly visible. You can appreciate uterine fundus, you can appreciate uterine body, and uterine cavity is clearly visible. In this uterine cavity, the endometrial thickening is ranging from 8 to 10 millimeter. So this endometrium is in proliferative phase. But again, I would mention here that the proliferative phase can be divided into two: early proliferative phase ranging from 2 millimeter to until 5 or 6 millimeter endometrial thickening, while late proliferative phase may vary from 6 to 10 millimeter. So this is what late proliferative phase. In the late proliferative phase, endometrial thickening may be up to 10 millimeter. So here you can confidently mention about the thickening of the endometrium. You can also appreciate the interface, myometrial and endometrial interface. Thickening is clear, there is no endometrial polyp, there is no endometrial hyperplasia, and always put the last menstrual LMP date on your report so that the gynecologist can correlate with the last menstrual period and take the history where the patient should physiologically be in the proliferative phase or not, and then he or she should correlate with the endometrial thickening. So if it is equal to the time what the patient is menstruating, so that is fine, and if it is any discrepancy, so it may be pathological. So this report, this image indicate that this patient endometrium is in late proliferative phase. So always mention on the report endometrial thickening measuring this, and whether it is in proliferative phase, which I have already mentioned, and or in menstrual phase, which in the last images you have seen, or if there is any fluid within the uterine cavity. So this is worth mentioning on your report. This is another image of secretory phase, transvaginal ultrasound. Here this white arrow indicating endometrium in secretory phase. So you can see there is visible thickening of the endometrium. In the secretory phase, there is secretory activity going on. That's why it is called as secretory phase. Normally menstrual phase divided into three: proliferative, secretory and menstrual. So in the proliferative we have discussed about the thickening. It could have been from 6 to 10, and in secretory phase it should have been from 12 to onward 22. It depends upon individual to individual, and also depend upon the hormonal secretions as well. So therefore, so far this scan is concerned, you can see there is a quite thickened endometrium. This patient was in a secretory phase, and her LMP was 2 to 3 weeks ago. So she was perfectly in secretory phase. Here you can see that the endometrium is visible. But one thing worth mentioning here, you should not have to take the entire length of the endometrium. Here it is actually covering the both lining, so you have to put the cursor in the middle and then take only the one part of the endometrium. So that would be the real endometrial thickening. Otherwise, if you are looking to the whole endometrial region, so it is covering the entire lumen, so it would be the double of the endometrial thickening, double of the size of the endometrium. So therefore, put the cursor in the center. Here slightly in the midline you can see a line or echogenic line which indicating the center. So from there you have to take the measurement, and that could be the true measurement. This is the technical point with most of the clinician correctly doing this, correctly measuring the endometrium. So therefore pay attention to this, that which way you have to take the measurement. So the measurement should be taken from the center to outward, and that would be true measurement. So this scan shows endometrium in secretory phase. So mention on the report thickened measurement, measuring so and so whatever the measurement is, and radiological finding, ultrasonic findings are suggestive of endometrium in secretory phase. Please correlate with last menstrual periods clinically. Here on this transvaginal scan, the uterine position is actually retroverted. So retroversion is visible here. Endometrial lining you can well appreciate, and even you can appreciate in the center, in the central line as well. So you have to take the measurement from the center upward. Both arrows are indicating endometrial thickening, so you should not take the measurement from one end to another one. You have to take the measurement from the center towards either upward or downward, and that could be true measurement. So again, this endometrium is in secretory phase, and its thickening is nearly 15 to 16 mm, and many clinicians also suggest that secretory phase can also be divided into two: early secretory phase and late secretory phase. Well, it's up to you if you want to, or you are confident enough to mention this early proliferative phase or late proliferative phase. This would be absolutely fine. But anyway, if you're just mentioning the proliferative phase or secretory phase straight away, that's again good. But always mention on the report, your report should have the last menstrual period timing on it. Your report should have the endometrial thickening, and in the conclusion must mention that the endometrial thickening is are corresponding to menstrual phase or proliferative phase or secretory phase, or whatever the condition is. You must mention that. Even if it is physiological, mention physiological changes. If it is pathological, so then mention these are pathological changes. Here again on this transvaginal scan, you can appreciate quite thick and echogenic endometrium. This uterus is anteverted and anteflexed. There is no abnormality in the position. Myometrium is absolutely fine, but you can appreciate thickened endometrium. As I mentioned earlier, that you need to have LMP of the patient on the record, so that one can correlate or compare with the radiological proliferation of the endometrium and also physiological pattern of the menstrual cycle. So that's why it's very important. As far as this image is concerned, you can see that endometrium is thick and it is echogenic, and this is probably late secretory phase. So you can confidently mention that this is late secretory phase, and if it is more than that, so then this would be pathological. So we will discuss about the endometrial pathologies in later slides, in later videos, but so far this video is concerned, it is purely based on the normal or radiological anatomy of the pelvic organ, especially uterus. So I'm not going to discuss about the pathologies of the endometrium here. So this scan, this image shows secretory late secretory phase of the endometrium. So mention this on the report and confidently give your conclusion that this endometrium is in secretory phase. Here on this transvaginal scan, you can see a clearly well defined uterus. This uterus is retroverted and retroflexed as well, but this is a postmenopausal status. Although the uterine myometrium is okay, there is no certain atrophic changes, but still in the endometrium you should have to measure, or you should have to take the endometrial measurement. Endometrial measurement in postmenopausal ladies are very important. It depicts certain pathology, and it also very important to look for the endometrial carcinoma. Normal postmenopausal endometrium should not have been more than 5 millimeter. It should be in between 2 to 4 millimeters. So that's why in postmenopausal the assessment of the endometrium is very important. And if in case they give you an history of bleeding, especially at that very moment, it is important to evaluate endometrial thickening. In this case, in this endometrial cavity, you can see there is 2 mm thick endometrium of the postmenopausal patient, which is quite normal. So this was a normal postmenopausal endometrial thickening. Myometrium. Myometrium is a muscular layer of the uterus. Actually, myometrium is consist of three layers, that is called as perimetrium, myometrium, and endometrium. Myometrial, as I mentioned, it has three layers. The two outer layers are very thin and delicate layer, while myometrial intermediate layer is thick and muscular layer. On the ultrasound, it shows a homogeneous pattern. There is homogeneous echogenicity. Ultrasonically, you can see so far the myometrium is concerned if there is no pathology. Beside this, it has been supplied by arcuate arteries, which supply the first and the second layer of the endometrium, and then it is followed by the spiral arteries, which eventually supply the endometrium. But in between, there is a radial artery as well. So arcuate artery, and it supplies the radial artery, and radial artery fully supply the myometrial part, but it further convert into spiral artery, which supplies the endometrium. So this is the vascular structure of the myometrium. As I mentioned, myometrium is having an echogenic pattern, homogeneous pattern, and it has its own particular appearance on the ultrasonography. In case of any pathology, you will find different pattern. You will find different pattern in the shape and in the echogenicity of the myometrium, through which we can understand whether some fibroid activity is going on, or there is any adenomyosis, or there is any calcification. Especially in postmenopausal female, there will be a heterogenic myometrium. You might come across tiny calcific foci within the myometrium. This could be because of age relation or because of atrophic changes. The one another point worth mentioning here: when endometrium and myometriums combine, that area is called as endometrio-myometrial interface. Sometime there is there's possibly calcification, and this could likely be because of post instrumentation. Many a time we come across with calcification, so we ignore that. That is actually because of post instrumentation, although it is not pathological, but sometime it give rise to some pathological processes as well. So how it will appear on the ultrasound imaging, how we will differentiate between different patterns, how it will look on the ultrasound, that it is hypervascular, there is low vascularity, how we will put the Doppler signals on. So this information will also included in this lesson. So let's start watching these images. Here on this ultrasound imaging, this is actually TVS scan, and on the TVS scan again this uterus is retroverted. So on this retroverted uterus, you can see endometrium, you can see myometrium and myometrial echogenicity. Normal myometrial echogenicity happens to be homogeneous. There will be no irregularity, there will be no heterogeneity, and again it depends upon the patient's periety, it depends upon the patient's menstrual cyclic changes. So therefore lot many changes you should have to keep in view. But so far the homogeneous myometrium is concerned, it appears normal. The one important thing on this image, which is indicated by the white arrow, these are small anechoic areas. These are actually myometrial veins. Some of the myometrial veins shows blood flow on Doppler imaging, while some of them does not shows any detectable flow on the ultrasonic on the Doppler imaging. This is the normal myometrium. There is no activity, fibroid activity or any other pattern, although this myometrial pattern shows slightly heterogeneous, but you should not confuse, because this is the normal pattern of the peripheral vascularity in the peripheral myometrium. It should not be confused with pelvic congestion syndrome, which I will discuss in later videos. but here this is a normal pattern. If up to that limit you can see the vasculature or peripheral vessel within the myometrium, so that would be absolutely fine. So this slide shows myometrium with peripheral myometrial normal venous structure. This is another transvaginal scan, and on this transvaginal scan you can see uterus fundus is visible, its body and lower uterine body is also visible. Endometrium is quite clear. Myometrium can be seen, but myometrial, peripheral myometrial shows increased vascularity. On the Doppler imaging, you can see these veins are filled with the fluid, so it's mean that there is increased vascularity. It's worth mentioning here that during the menstrual phase or early or late secretory phase, there is increased vascularity, and afterward the menses ensues. So therefore at that time there would be increased vascularity within the myometrial area. Here myometrium is okay, although homogeneity is not quite clear because of the vascularity, but normally myometrium happens to be homogeneous and there should not be any fibroid activity or there should not be any other pathology. Sometime you can appreciate calcification, sometime there are multiple cystic lesions within that, or many other abnormality can give rise to some heterogeneous myometrial echogenicity. So for this scan is concerned, this scan is totally normal, and this is the normal vascularity in the peripheral myometrial region. This is the slide of post-menopausal patient, and it shows arcuate artery calcifications. The sagittal transvaginal scan demonstrate multiple echogenic foci in the outer myometrium due to arcuate artery calcifications. A normal thin endometrium is also seen in this postmenopausal patient. You can appreciate here. This is the postmenopausal case. Although the position of the uterus is anteverted, there is no positional abnormality. But here you can see thin, tiny calcific foci in the peripheral myometrium. That is because of the arcuate artery, arcuate supply, blood supply. So arcuate artery supply outer and middle myometrium, and then further it is supplied by the radial artery, and then spiral artery supplies the endometrium, which I have discussed earlier. So here this is the pattern. If you come across any calcification, look forward for the menstrual history, whether patient is pre-menopausal or post-menopausal. In post-menopausal, these calcifications are normally, and this is because of some other pathological processes, not really pathological processes, but because of senile degenerative changes, this calcification may take place. So you have to mention on the report that the patient uterus is normal in size, myometrium shows some postmenopausal changes with multiple dense tiny calcific foci settled in the peripheral myometrium. So you have to just clarify that, and further correlation with the clinical examination and the patient history is recommended, because if the patient is symptomatic, so one should take account of these calcification and calcific foci and goes for further imaging. But if there is no symptomatic and you randomly come across with these calcific foci within the uterine cavity and the patient is postmenopausal, so then there is no need for further workup, and this is just the normal case. So this was an example for you to have a look for. This is another transvaginal scan. Uterus is normal in size, in shape, and its position. It's anteverted uterus, and here these white arrows are indicating tiny foci, tiny calcific foci. Actually this is the area and which is called as endometrio-myometrial interface. So this is the interface where you can see calcification, and this is considered to be post instrumental. Many a time if the patient undergoes through certain instrumentation because of any reason, so the endometrium interface may get calcified, and this tiny calcific will appear on the images. So therefore when you are writing on your report, mention that tiny calcific foci can be seen in the myometrial endometrial junction or myometrial endometrial interface. Rest of the scan is fine, there is no problem. So you can also give your suggestion that previous history should be considered, correlation with previous medical record should be considered for this tiny calcification, and because this could be likely post instrumental calcification. Uterine cervix. As I mentioned that uterus has three parts: main body and fundal part and cervical part. Cervical part is very important. Cervix is actually having two areas: internal os and external os. Although we cannot appreciate this internal and external os on non-pregnant uterus, but when there is pregnancy, this is really vital to measure internal os diameter, because sometime abortion may take place if there is widening of the internal os, or if there is any discrepancy in the opening point of the internal and external os. So that's why it's very important. But otherwise, on the ultrasound imaging, if you pay attention, you can still appreciate cervical canal, and if there is any pathology within the cervical canal, still it can be appreciated. Cervical myometrial pattern can also be seen. Thickened muscular layer can be found, else can be appreciated on ultrasound as well if it needs slight attention. Beside this, there you can find multiple cysts over there that are called as Nabothian cyst, because of mucosal retention at this area is responsible for the mucus secretion, cervical area. So therefore you may come across certain Nabothian cysts. If it these are if these gets infected, that it will become very painful. But if it is not, normally you will see either single or multiple Nabothian cyst in the cervical region. So pay attention to the cervix, because cervix is very important. Many a time while scanning the uterus, we concentrate on the cervical part, we pay attention on the body, but we usually forget the cervix. You have to look for the cervix, take the full measurement of the full body, and then the cervix separately as well, because again the size of the cervix is vary in non ovulatory patients, in pre-ovulatory patient, post ovulation. This is all different. It depends upon the aging. If a patient is before the menarche, the size of the uterus and the cervix is different, and it will appear as a dumbbell shape, and when post menarche, the size and the shape would be different. But actually we are supposed to pay attention to the pathologies, because abnormality, so far the only cervix is concerned, that is also a special topic which I will discuss in Mullerian duct dysgenesis, and again very important topic. So I'm not gonna confuse you at this very point, as you know that this video is related to the anatomical portion. We have discussed the myometrium, we have discussed the endometrium, we have discussed the anatomy of that. Now it is a point to look for the cervix and the Nabothian cyst. So how it will appear on the ultrasound images, let's start watching this radiological anatomy of the cervix. Have a look for the cervix on this transvaginal scan. Uterus is normal. Half of the body of the uterus can be seen on this image, but basically focus has been given to have a look for the cervical area. Within the cervical canal, you can also see an echogenic line. This is cervical lining. So cervical lining is also visible. So on the scanning, you can evaluate cervical pathologies very clearly if you pay attention. So you can find out any pathology within the cervical canal. If there is any problem within the cervical canal, you can find out. If there is any cervical intracanal polyp, so you can also appreciate that on the transvaginal scan. You can, although you cannot appreciate internal and external os clearly, until the patient is pregnant. In the pregnancy, internal os evaluation is very important, which I will discuss during the obstetric scanning. Here you can appreciate only the entire length of the cervix, so you can measure this length as well. You can well indicate that the measurement of the cervical canal is that much, so length can easily be given on these images. Here external os cannot be accurately measured, although you can see there. So far the cervical scanning is concerned, it is obvious that you can see and you can appreciate any pathology related to cervical canal, cervical itself. So far the cervical erosions are concerned, erosion cannot be picked on the sonography until there is any gross pathology, or there is any abscesses, or there is any cystic formation. So you can pick that on the ultrasonography, but not the laceration. So this is the normal cervix on the transvaginal scan. This is another transvaginal scan, and on this transvaginal scan the cervix is clearly visible, cervical canal is visible. On the posterior wall you can appreciate a well-defined simple cystic lesion with aquastic enhancement. So this is actually cyst. Why it appears here, the reason of the cystic lesion in here is because of mucus retention. So this uterine part is rich with the mucus secretory glands. Sometime there is likely chance that one may get blocked and it appears cystic lesions like this one. So here particularly it is called as Nabothean cyst. Nabothean cyst may be single, may be multiple, but it depends on its number. So mention that Nabothean cyst can be seen in the cervical posterior wall, measuring that much, and always mention the internal contents, whether there is any internal contents within it or not, any calcification or not, because if it is simple, so it will not give you any symptom. But if it get blocked, or it get infected, or there is any hemorrhage take place within the Nabothean cyst, so this would be very painful and it need immediate attention. So therefore always comment on the internal structures of the Nabothean cyst. Mention that this size Nabothean cyst can be seen in interior or posterior wall of the cervix. This is another transvaginal slide, and on this slide you can appreciate cervical part. Cervical canal is also visible, but here you can see at least 4 to 5 small cystic lesion with aquastic enhancements. So these are again Nabothean cysts. As I mentioned you earlier, that it is not important that there will be only singular Nabothean cyst. It likely happens that there may be multiple or sometimes numerous Nabothean cysts, but it will give rise to symptom. It depends upon individual to individual. Certain Nabothean cysts are quite asymptomatic, and sometimes if it gets blocked with any infected material, so it will give rise to symptoms. So here this slide shows multiple Nabothean cysts on transvaginal scan. This is worth looking slide. Here a white arrow indicating a cystic lesion, and this cystic lesion shows low level internal echoes, and just beneath that there is another cyst which is clear, and internal lumen does not show any low level internal echoes. So this slide is showing cervix on the transvaginal scan, and these both are Nabothean cyst. One is simple Nabothean cyst and another one is hemorrhagic. It is filled with hemorrhagic contents, so that's why it will be a hemorrhagic cyst. Hemorrhagic cyst happens to be very painful, so definitely this patient will be having severe pain in the cervical area during the examination, per vaginal examination, or during any instrumentation. In any instrumentation, the patient will give you symptoms that there is pain and she cannot tolerate that. So that could have been because of this hemorrhagic cyst. So mention on the report that in the cervical canal or in the cervical anterior or posterior wall there is a cystic lesion. Give its measurement, and it has low level internal contents, If possible, you can give volume of the cyst as well, but mention that the ultrasonic features are suggestive of hemorrhagic cyst. Further correlation is recommended with clinical record and patient history. On this transvaginal scan, you can appreciate cervix, and on the cervical area, these white arrows are indicating cervical fold. These are actually cervical fold, but this is very rare entity, although it is quite normal finding, and these cervical fold can be called as plica palmatia. But again, I would say that this is not a pathological process. This is quite normal. So if you come across any such type of a feature, so you should not confuse, just straight away mention that these are cervical folds, and on the conclusion you can mention that these are called as plica palmatia, and there is no pathological process in the cervical region. Cervical calcifications are also very common. Again, these are insignificant. There is no such pathological processes. But in case if patient is symptomatic and patient mucosal discharge is very high, so then possibility of any infection may be considered. This on this scan, you can appreciate the cervix and cervical canal is slightly extended. Mucosal proliferation can be seen, and beside this, tiny calcific foci can also be seen. So this is what normally you can appreciate that. But if in case the calcific foci are more or numerous, and there is thickened fold and thickening of mucosa, so then this could be pathological. This is quite interesting slide here. This area, this hypoechoic lesion, which is indicated by certain measurement, this is called a cervical pseudoma. This is not the pathological processes. This happens because there is a twist in the cervical neck and cervical body when it is joining with the uterus. So because of that twist, small muscular fibrillar pattern appears in such a way that it will mimic as like there is a tumor. So you should not confuse with all these pattern. This is a normal pattern, and you always look for the both transverse and longitudinal imaging. When you are looking in both, when you will look in both directions, it will clarify that this is not the real mass. This is actually what the pattern of fibrillar pattern of the muscles of the cervix. So this is called as pseudomass, and you should not mention this on your report. This is for your understanding, that you can put on your, you should not put on your list, on your record, on your ultrasound report, that lesion can be seen within the cervical region. Now this is just for your understanding, that you should not confuse yourself with any of the pseudomas or any pseudomass. So this is what the normal pattern, and sometime the cervical region will look like this. Yes, friend, this was all about the uterus. I have discussed, and I have tried to discuss at length the different components of the uterus: fundus, body, myometrium, endometrium, and cervix. So today I have covered radiological anatomy of the pelvic organ. I have also discussed in this video which type of a scan you can use for the scanning the pelvic region. What are the importance of the transvaginal scanning, where we can utilize this transvaginal scanning. Beside this, one of the very important point that was related to anti-flexed and antiversion and retroflex and retroversion position of the uterus. I do hope that this would be a very helpful video for you. Keep watching these videos. The next video would be related to congenital abnormalities, Mullerian dysgenesis. This would be really very important video, and I'm trying to put all of my information and experiences in that video, and will upload next month, rather next week. So keep watching my video, keep sending me your information, your feedback, and keep sharing this video to the other colleagues as well. Look after yourself and look after your patients as well. Take great care of those who love you. We will see each other in the next video. Till then, bye bye.